Hey everyone, this is Caitlin Briscoe. I chose to do my master's project on cystic fibrosis. It is a topic very near and dear to my heart as it affects my family. We are going to begin by discussing some of the general features of cystic fibrosis, including the etiology and pathophysiology. Cystic fibrosis is an autosomal recessive genetic disorder that is most commonly seen in Caucasians. It affects 1 in 3,000 live births. Cystic fibrosis is caused by a mutation in the gene that codes for the cystic fibrosis protein transmembrane conductance regulator. If it is functioning correctly, this protein regulates the movement of sodium and chloride ions across the cell membrane. Therefore, a defective gene results in the accumulation of thick mucus in different areas of the body and affects many different organ systems. However, the effect on the respiratory system is the most pronounced because it can lead to chronic lung disease and pulmonary failure. Now we're going to talk about the clinical assessment, including the signs, symptoms, and physical examination. Symptoms of cystic fibrosis often begin in infancy, with respiratory manifestations being the presenting complaint in the majority of patients. The most common initial symptom of cystic fibrosis is a chronic cough that eventually becomes more persistent and may produce mucopurulent sputum. Children will often show signs of wheezing and tachypnea associated with episodes of bronchiolitis. Other significant respiratory symptoms include progressive dyspnea, recurrent pneumonia or sinusitis, and hemoptysis. Cystic fibrosis also affects other organ systems, including the gastrointestinal and genitourinary tracts. Common GI symptoms of cystic fibrosis include a meconium ileus, failure to thrive, abdominal distension, fatty stools, GERD, and pancreatic insufficiency. Undescended testes in males and fertility issues in males and females are common signs of cystic fibrosis that manifest in the GU tract. It is important to conduct a detailed physical exam in a cystic fibrosis patient to assess for disease progression and possible complications. The effect of cystic fibrosis on the respiratory system is the most severe and potentially life-threatening. Hyperinflation of the lungs is common in CF patients, so hyperresonant percussion tones is a possible finding. Wheezing or crackles may be heard on auscultation of the lungs. Additional findings may also include clubbing, rhinitis, or nasal polyps. If the patient is in respiratory distress, retractions and cyanosis may be observed. Vital signs could also demonstrate that the patient is tachypnic. Because cystic fibrosis also affects the GI system, an abdominal exam including auscultation, percussion, and palpation should be completed. Any abnormal findings, such as tenderness or abnormal bowel sounds, may be an indication of GI complications, such as acute pancreatitis or intestinal obstruction. So how is cystic fibrosis diagnosed? Today, the majority of patients with cystic fibrosis are detected using the newborn screening. Positive results on this test warrant the newborn undergo sweat chloride testing to confirm the diagnosis of cystic fibrosis. The sweat chloride test is the gold standard and primary diagnostic test used in CF. If a patient has a positive result on the sweat chloride test, they may undergo genetic testing to determine the patient's genotype, which will provide important information to reveal which treatment option is best for that patient. Patients with a confirmed diagnosis of cystic fibrosis must be closely followed to monitor for any complications. Chest imaging, such as radiographs and computed tomography, are commonly used modalities to follow any lung changes associated with CF. The lung function of these patients can be monitored using pulmonary function test. A decline in the forced expiratory volume in 1 second on a PFT has been linked to the progression of cystic fibrosis. After a patient has a confirmed diagnosis of cystic fibrosis, it is important to discuss the treatment options available. The management of cystic fibrosis is aimed at treating the underlying cause of the disease and preserving lung function. A new class of drugs, known as CFTR modulators, target the specific mutation in the CFTR gene. Two different CFTR modulators have been developed with complementary methods of action. These include CFTR correctors and potentiators. CFTR correctors enhance the amount of available CFTR at the cell surface, and CFTR potentiators increase ion transport across the cell membrane by raising the likelihood of channel opening. Additional treatment options used in cystic fibrosis patients include chest physiotherapy, inhaled hypertonic saline, and mucolytics. Chest physiotherapy helps to remove mucus buildup from the respiratory tract and improve lung function. Inhaled hypertonic saline aids in the hydration of the airways to increase mucociliary clearance. Mucolytics are used to decrease the viscosity of the mucus and allow for easier airway elimination. Prophylactic treatment with inhaled antibiotics is used to reduce the risk of pulmonary exacerbations and suppress infection in CF patients with persistent Pseudomonas aeruginosa infections. During pulmonary exacerbations, patients require the addition of oral or IV antibiotics depending on the severity of symptoms to their treatment regimen. The antibiotic class of choice used in the treatment of Pseudomonas aeruginosa infections is the fluoroquinolones. Even though there is no cure for cystic fibrosis, a lung transplant is the only definitive treatment for the disease. However, only patients with severe bronchiectasis, end-stage lung disease, and an FEV1 of less than 30% on PFT are candidates for surgical management. Now we will discuss the prevention and prognosis of cystic fibrosis. In order to prevent CF, anyone with a family history or a relative with a known carrier of a CFTR gene mutation should undergo cystic fibrosis carrier testing. If both parents are found to be carriers of cystic fibrosis, they should be offered preconception counseling, during which alternative conception methods should be discussed. These methods include sperm or egg donation and pre-implantation genetic testing. Affected individuals may also choose not to reproduce. This is important because when cystic fibrosis was first discovered, it was terminal in infancy. However, with advances in modern medicine, the average age of survival has now increased to approximately 40 years of age. And here's my references. Thanks, guys.